This is Medicine Matters, the Springer Medicine podcast. Hello, and welcome to episode 2 of Medicine Matters. I'm Dr. Jane Godsland, Clinical Director of Springer Medicine, and in this episode we'll be focusing on an oncology topic, specifically the latest data on PARP inhibitors in prostate cancer. For the non-oncologists among you, PARPs, or poly-ADP ribose polymerases, are enzymes that play a really crucial role in various cellular processes, including transcription, replication, proliferation, and DNA repair. PARP inhibitors stop the PARP from facilitating the cancer cell repair and leading to cell death. They were initially identified as therapeutically useful in BRCA-associated cancers such as ovarian and breast cancer, but in 2020, the FDA approved the first 2 PARP inhibitors for the treatment of metastatic prostate cancer. As the second most common cancer diagnosed in men, there is considerable expectations around the revolutionary effects of this targeted treatment approach. To keep you up to date, my colleague Shri Ananda interviewed Dr. Elena Castro about the latest evidence on PARP inhibitors in prostate cancer from data presented at the 2023 ASCO Genitourinary Cancers Symposium.
Hello, I'm Dr. Shri Ananda, Senior Clinical Content Manager at Springer Medicine. I'm here today with Dr. Elena Castro, who is a GU medical oncologist at the 12th of October University Hospital in Madrid, Spain. Thank you so much for joining us, Elena.
Thank you for inviting me. It's my pleasure to be with you today.
To start with, perhaps you could just tell us a little bit more about yourself.
Well, I'm a medical oncologist currently in Madrid, but before that, and after completing my medical oncology training in Salamanca, I spent 4 years at the Royal Marsden and the Institute of Cancer Research. From there, I moved to the Spanish National Cancer Research Center. I was there as a clinician scientist for almost 7 years before moving to the Institute of Biomedical Research in Malaga, and from there I moved to my current institution in September 2022.
Great, thank you. So ASCO GU is always a very exciting conference, I think. It's one of my favorites. And again, it was very exciting this year, especially around the PARP inhibitors data that was presented. So could you briefly outline some of the key studies that caught your attention?
Well, I think this year very relevant, very important studies were presented at ASCO GU, presented or updated, that help us fill in some gaps that we have regarding PARP inhibitors in prostate cancer. We learned the data from the Triton-3 study. Triton-3 is a phase 3 trial that investigated the benefit of rucaparib for the treatment of patients with BRCA1, BRCA2, or ATM alterations who have already progressed to 1 line of hormonal therapy with androgen receptor pathway inhibitor. These patients could have received chemotherapy in the metastatic hormone-sensitive scenario, but not for mCRPC. And the data was, I think, is very relevant. We've learned that patients with BRCA alteration clearly benefit from rucaparib compared to other physician choices, including a second hormonal agent, but also compared to docetaxel. And this study is very important because it is the first time that a PARP inhibitor has been directly compared with docetaxel. It was very clear that for patients with alterations in BRCA, the PARP inhibitor resulted in improved radiographic progression-free survival compared to chemotherapy. However, for patients with alterations in ATM, no benefit was noted from the PARP inhibitor, rucaparib in this case, versus chemotherapy or a second hormonal agent. I think this is very relevant. Because this study has provided a direct comparison with taxanes, it also allows us to compare toxicities. So what we've seen is that the toxicity of this agent is different. We already knew that, but we have seen a similar prevalence of fatigue with both therapies, but then the anemia is significantly more frequent with PARP inhibitors. This was to be expected. This is associated with this type of drugs. But 1 in 4 patients treated with rucaparib require a blood transfusion at some point during the treatment.
So some really good data there from the Triton-3 study. And a quite clear message, I would say, for the use of PARP inhibitors in those with ATM mutations. But what can you tell us about the use of these PARP inhibitors in combination with other agents?
We have now data from 3 trials that are investigating these combinations for the first-line treatment of patients with metastatic castration-resistant prostate cancer. In this meeting, the data from the TALAPRO-2 study was presented for the first time, and we also have updates on the magnitude and the PROpel studies. So these 3 studies are combining different PARP inhibitors, niraparib in magnitude, olaparib in PROpel, and talazoparib in TALAPRO, with different hormonal agents. Abiraterone is used in magnitude and PROpel, whilst the TALAPRO-2 has used enzalutamide. And it is possible that because these agents are different, the synergies between the ARPs and PARPs are different, and the efficacy of this combination may also be different. Of course, we don't have direct comparison between these 3 studies. So the TALAPRO-2 study has demonstrated that the combination of enzalutamide plus talazoparib for the treatment of patients with who have not received previous treatment for mCRPC resulted in improved rPFS. The benefit was noted for all patients in the study, but was even more evident for patients with alterations in the homologous recombination genes. I think something that was quite relevant to me was that the investigators repeated the analysis, excluding those patients in which the HRR status could not be established because these samples fail sequencing. And when focusing in the patients in which they could clearly not identify any genomic alteration in HRR genes, still they saw a benefit from combining talazoparib and enzalutamide versus enzalutamide. Of course, we need to learn more about the characteristics of the patients that we call HRR negative, the patients that don't have genomic alterations in these HRR genes. But I think this is a very remarkable finding. And in this study, the hematological toxicity in the combination arm was very significant. About 40% of patients treated with talazoparib presented with grade 3 or 4 anemia, and of course, many of them required a blood transfusion. This was a side effect that could easily be reverted, and then is about 8% of patients in the combination arm that finally discontinued treatment due to anemia. But still, I think it's a very significant toxicity, and we need to be vigilant and monitor patients carefully.
That's a really interesting finding, I think, in the HRR negative population. I think it would be really interesting to see whether that is repeated or observed in other trials as well. And any other highlights to share?
In this ASCO GU, we have seen updates on the magnitude trial. The magnitude study is investigating the combination of abiraterone and niraparib for patients with alterations in HRR genes, because in a futility analysis that uh, try to establish the benefit of this combination in patients without HRR alterations, no benefit was noted, and then this part of this study was closed. So magnitude is focused only in patients with HRR alterations. We have learned that with additional 8 months follow-up, the benefit in rPFS for patients with BRCA alterations and alterations in other HRR genes is maintained, very similar to the data that was presented at ASCO GU last year. And some early data on overall survival was also presented. The data is still immature, but when the analysis took into consideration some imbalances in the baseline characteristics of these patients, and also took into consideration that some patients in the control arm received PARP inhibitors outside the trial after progression to abiraterone, there is a positive trend towards a benefit in overall survival for patients with BRCA alteration. So we still need to wait for more mature data, but this is this goes in the right direction as well. And the magnitude study presented also a very a small exploratory analysis, but also quite relevant analyze, because magnitude allowed patients to start treatment with abiraterone while the molecular analysis was being performed. So patients could be on abiraterone for up to 4 months before being randomized in the trial. And what the investigators have reported is that for those patients who were on abiraterone for less than 2 months, the benefit of the combination was maintained. But for those patients who were on abiraterone before starting the combination for more than 2 months, then the benefit seems to be lower, seems to be less. So, of course, the number of patients in this analysis is limited, but it also provides, I think, some relevant data for future analysis.
So I guess the closing down of the magnitude HRR negative arm speaks to my question earlier about whether the findings from TALAP-Pro2 would be repeated. And I guess it just means that this is an aspect that needs to be researched further, teased out further. I guess we just don't know enough. But let's move on to the last study that was presented at ASCO GU. What can you tell us about the data from PROpel?
Previously, we have seen that the combination of abiraterone and olaparib resulted in improved rPFS for all patients, but especially for patients with alterations in BRCA, and also for patients with alterations in other HRR genes. What we have seen at this year at ASCO GU is that the combination of olaparib and abiraterone resulted in an improved overall survival in all comers, 7 months prolonged overall survival. However, this difference was not statistically significant for all comers. If we look at the different subgroups, then the patients with BRCA alteration got a spectacular benefit from the addition of olaparib with a hazard ratio of 0.29. I think this is spectacular. We are not used to see these differences in phase 3 trials in prostate cancer. The benefit for patients without BRCA alterations is debatable. If we focused now in patients with alterations in other HRR genes beyond BRCA. The benefit was less than for BRCA patients, but it still was a positive improvement in overall survival. But for patients without HRR alterations, we are in the same situation as before. There's not a clear benefit in overall survival for these patients. And with all this data I just commented on, I think we have now a big controversy on whether we should be using these PARP inhibitors alone or in combination for patients with BRCA or HRR alterations, and whether the combination of these agents could be beneficial for all mCRPC patients, regardless of their mutational status.
Thank you so much for that excellent summary. There were a few studies that I actually missed, so the smaller analysis, the sub-analysis of magnitude, I will go and look that up. So many interesting developments. What impact do you see these having on clinical practice?
So we've learned from these studies is that for patients with ATM alterations, the PARP inhibitors may result in very limited benefit, and perhaps we can spare these patients from the toxicity associated with these type of drugs. For patients with BRCA alterations, we've learned from Triton, that the Triton-3 trial, that after progression to an androgen receptor pathway inhibitor, we shouldn't wait and to use a PARP inhibitor. The benefit from these drugs is much greater than it is from chemotherapy, from docetaxel. So we should try to use these PARP inhibitors as soon as possible. And from the trials investigating PARP inhibitors in combination with androgen receptor pathway inhibitors, we've learned that the combination of these agents results even in improved overall survival for patients with BRCA alterations. So we should screen our patients as soon as possible and try to use the PARP inhibitor in combination, because this is the data we have at present as first line of therapy for patients with BRCA alterations. For patients with, and perhaps also for patients with other HRR alterations. For patients without these molecular events, well, I think the benefit is less clear, and still these patients will have to endure the toxicity associated to PARP inhibitors. This is a discussion we will have to have with our patients one by one, considering their options, their preferences, explaining them that we don't really know which could be the benefit, but it seems to be a benefit in some patients that we still need to characterize better, and also monitor the toxicities very carefully.
Thank you so much. That's some really good takeaways for physicians there. I'm just wondering now, so what else needs to be addressed? What are the research questions that remain unaddressed or have arisen from the data we have seen?
Yes, well, I think it is clear that for patients in which we do not identify genomic alterations in HRR genes, there's still some patients who really benefit from the combination. So who are those patients? Do they have any type of impairment in the homologous recombination pathway that we are not detecting, but by looking only at genomic events? It could be that they have, expression, other type of alterations that sensitize them to PARP inhibitors. We need to characterize this population better. And also, these three trials, Magnitude, PROpel, and TALAPRO-2, did not include only a very limited number of patients who had already progressed to hormonal agents in the earlier stages, in the non-metastatic castration-resistant stage or the hormone-sensitive metastatic stage. So we don't really know whether after progression to these agents, the addition of a PARP inhibitor could result in improved efficacy or could help to overcome cross resistance with between this type of agents. So we need also more data on that.
One last thing. So do you think there is scope for sequencing these different PARP inhibitors?
Well, we don't know. In theory, the mechanisms of resistance to them is similar. So I will assume that if with the current PARP inhibitors, probably once the patient has become resistant to one of them, it's very likely to be resistant to another. But we don't really have much data about that. And we don't really have much data either for the use of carboplatin-based chemotherapy or platinum-based chemotherapy after progression to a PARP inhibitor. There are some small series with very limited number of cases that have reported some responses, but we need more evidence. And this is a very important question, because if we start identifying who are patients with BRCA alterations, how are we going to treat them once they become resistant to the first PARP inhibitor? So I think, or I believe, that in some time we will have more answer to your question that will become more and more relevant.
So yeah, I will just wind that up by saying that was an excellent summary of the data presented at ASCO GU around PARP inhibitors in prostate cancer. You provided an excellent discussion, and thank you so much for that. It's going to be great for our listeners, I'm sure. And yeah, thank you so much for taking the time to speak with me today.
No, pleasure.
Huge thank you to both Elena and Shreya for a really valuable update on where we are with these promising treatments in prostate cancer. If you found this conversation useful for your practice, please do like and subscribe to the podcast and visit us at springermedicine.com, where you can register for our update newsletters tailored to your practice. This podcast is intended for healthcare professionals for their ongoing medical education and entertainment. It should not replace the professional advice of a doctor or pharmacist and may not be used as a basis for diagnosis or any change to the prescribed treatment of disease. The views expressed by our moderators and guests are their opinions and do not represent the position of any third parties. The information given in the podcast is subject to change as the scientific field and clinical advances progress.